Thank you, Dr. Chitra, for inviting me to this course. I would talk about interface challenges and solutions, but for the past like 10 years, 12 years now, I've mainly been doing SMILE. So my focus would be on interface challenges in SMILE, but we'll also then talk about some of the challenges you can face with LASIK. An interface is an interface, whether it is with SMILE or with LASIK. So it is quite common to have common problems between the two. I am a consultant to Carl Zeiss, Meditech, and Biotech. First, I would like to talk about an important study that we did with SMILE, interface healing and visual recovery, that we published in the IGO. So we wanted to study the time course of interface healing and its correlation with visual acuity, MTF, abrasions in SMILE. And the recent literature had showed that optical quality and visual recovery were attributed to micro distortion at the Bowman's membrane, dependent on the refractive error and lenticule thickness, and they said that it contributed to the slightly slower visual recovery in SMILE. But since the SMILE interface is deeper, 120 microns, compared to the Bowman's, which is at 55-60 microns, we believe that interface healing also plays a key role in visual recovery after SMILE. Even with LASIK also, the quality of the interface basically influences the recovery, visual recovery. So to evaluate the morphology of the interface after we did the study, we dilated the pupil and took retroillumination photographs. So this is something which you can all do in your practice to evaluate the interface, even if you don't have a OCT, a high resolution OCT, or something that measures scatter, whether it is with LASIK or SMILE. If you want to actually look at how the interface is healing, you can just dilate and take clinical photographs. So we had 5 standard templates representing 5 grades of granularity or roughness. And these were created by an independent observer from 234 post-op photographs of 78 study eyes taken on day 1, 2 weeks, and 3 months follow-up. So this was how we graded. So grade 1 to grade 5. So you can see the granularity of the interface. And we looked at correlation of the preoperative spherical equivalent, post-op corrected distance visual acuity, corneal MTF, Strell's ratio, higher order aberration, and interface roughness grade at 1, 2, and 3 months post-op visit. And you can see these were the results basically. So at day 1, we found that again the MTF, Strell's ratio, and the RMS factor was higher. And we looked at the interface roughness at post-op day 1, 2 weeks, and 3 months, and correlation between the interface roughness and visual acuity over time. And we found that the visual acuity and quality of vision improves as the granularity reduces, and the granularity reduces over time. So it was one of the first studies to evaluate interface healing with clinical photographs. And this can be used as an inexpensive and simple tool to monitor changes in healing patterns and reassure apprehensive patients, because you can see that the granularity keeps improving, and so does the quality of vision. So many of you all may have patients who come in and say that I see a little bit of doubling when I look at edges. And this is again because of the excessive scatter. And this you can actually make out when you take retroillumination photographs of the interface. So it's a very simple tool that you can use to assess the interface. So let's go on to the challenges and solutions. One of the commonest problems that you can face either with LASIK or SMILE is DLK. DLK is a non-infectious inflammatory condition that can occur in the early post-op period, usually 24 to 48 hours. And it can be an asymptomatic interface haze in the peripheral edge of the flap, or it can even involve the center. So you have various grades. Usually there are many reasons for DLK, but the commonest is because of the sterilization techniques. And if you have poor sterilization process, and it was found that in these when you have these crops of DLK, it was found that many of them were using the statin where they were not changing the reservoir fluid. So the organism, usually like a gram-negative bacteria like Pseudomonas, which has a capsule, used to grow. And when you do the sterilization, the endotoxins, the capsule endotoxins get deposited on the instruments, and you use these instruments for dissection and in the interface, and this causes the inflammation and then the DLK. So specific, of course, there have been a lot of studies with LASIK, but again with SMILE do you get DLK? Again, it is quite rare, but there are a few case reports of DLK after SMILE, and any corneal procedure where you have an interface, you can get DLK. At our center, we evaluated the patients. Past 1 year, we had a few cases of DLK. The sample size was more than 1,000 eyes, and we also looked at the vision and the OSI. We had 18 cases of DLK, 11 were grade 1, and they were managed by just stepping up the topical steroids, and 7 eyes had grade 2 DLK, and if they have grade 2 DLK, early intervention is better. You have to wash out the interface, you have to remove the endotoxin. Once you remove the endotoxin by washing it out, then it will kind of settle down. And the mean logMAR uncorrected distance visual, corrected distance visual acuity at presentation was 0.18 and 0.16, and they improved to 0.1 and minus 0.3, which is almost 6 or better at by the end of the resolution. So the cases presented at a mean of 2.7 days, and resolution was seen in about 9 days. And so if you recognize the DLK early and manage it using the appropriate approach, it results in satisfactory outcomes without permanent effects on the visual acuity. There may be other reasons also, depending upon the amount of laser energy used, but nowadays we use low energy lasers. So DLK caused by the laser actually is quite rare, and you can use OSI, which is objective scatter index, as an effective tool for early recognition of DLK. The other problem that you can get in the interface is pressure-induced stromal keratitis, or what is also called interface fluid syndrome. And the cause is because of a elevation in IOP secondary to steroid response. Presentation usually occurs within a week, and the patient comes with worsening of vision, pain, elevated IOP, and sometimes you can see the visible fluid clefts in the interface. So management is early diagnosis, appropriate management. Otherwise, you can have glaucomatous patient going in for glaucomatous optic neuropathy. You'll have to lower the IOP with topical hypotensive agents and anti-glaucoma medication. So avoid dorsalamide. Some of the this is a 27-year-old male with chief complaint of diminution of vision since 1 week, and he had undergone the SMILE procedure 5 weeks ago, and he said his vision had reduced from 1 week. There was no history of redness, watering or photophobia, etc. Yeah, this is the 5-week post-op. You can see that his vision had dropped to 6/12, best corrected to 6/9, and he was using the steroid drops twice a day. Even though he was asked to stop after 4 weeks, he had continued to use the steroid drops. And you can see that there is this is the right eye and the left eye. There's a generalized epithelial haze. Interface is clear, but it appears widened. You can see this widening of the interface, and you can see the fluid in the interface and the cleft there. So when you do a high resolution OCT, you can look at it and see that. And you'll have to do the BIOP with the Corvus, and you can see with the NCT it may appear within normal range, but since you have removed tissue, ideally it should be lower than the pre-op IOP. So always you look at the pre-op IOP and the post-op IOP. The post-op IOP should be lower. If it is not, then there may be a steroid response. The BIOP typically shows that when it's corrected for the biomechanics, it is higher, 22 and 23. And the OSI also has increased slightly. So we stopped the predecetate and put him on anti-glaucoma medications. And you can see that at 6 weeks, the vision had improved to 6/6, and the pressure had come down also to 12 and 17. This was pre-op, before stopping the predecetate. You can see the cleft, a fluid cleft, and this was after stopping the predecetate. And there are a lot of publications on this. Other problem you can have is interface debris and foreign body from various sources. Basically, most of the debris is biodegradable, does not need any intervention, but if it involves the visual axis or is causing inflammation, then you will have to irrigate the interface and remove it. You can prevent it by proper draping and cleaning away the meibomian secretions and using powder-free gloves. Retained lenticules can be a problem with SMILE. They cause irregular astigmatism, and the reasons could be black spots, dense OBL, thin lenticules, improper dissection, and it's a unique complication of SMILE. Management is, if it's small tissue tags in the periphery, there's no need for intervention. But if there is a large fragment, especially in the center, then you'll have to do a surgical exploration and remove it. Again, because of paucity of time, I will just conclude here. There are other problems also which are more common in LASIK, like epithelial ingrowth and interface infectious keratitis, but it needs much more time, and so I think I will just conclude because of the pause.